Hi, Peter Johns here, vertigo maven from the University of Ottawa. If you've been watching my videos, you probably wouldn't be surprised to learn that I diagnosed this woman who was having constant dizziness with right vestibular neuritis using the HINTS exam. She had horizontal nystagmus beating to her left. Nystagmus that is seen when someone is looking straight ahead, that is, in primary gaze, is called spontaneous nystagmus. And yep, she sure does have it. But what about this woman with 2 days of constant dizziness? Could she be having vestibular neuritis? In fact, she also had right vestibular neuritis. But you don't see spontaneous nystagmus. So how did I make the diagnosis?
I've had some of my colleagues miss the diagnosis of vestibular neuritis when they didn't detect subtle nystagmus that their patient had. I'll show you how you can use a blank piece of paper to avoid making that mistake.
Let's go back to patient 1, whose nystagmus could be easily seen. She had constant vertigo lasting many hours that was worse with head movement, nausea, vomiting, difficulty walking, and she had spontaneous nystagmus. So when you have all of those features in one patient, that's called the acute vestibular syndrome, or AVS. But you don't rush to the HINTS exam just yet. First, you have to screen your patient for central features. They are focal weakness or paresthesias, new significant headache or neck pain, vertical nystagmus at rest, diplopia, dysarthria, dysmetria, dysphagia, dysphonia, and inability to walk unaided. Why is it important to screen for central features? Because the basic differential of the acute vestibular syndrome is vestibular neuritis, which is more common, and posterior circulation stroke, which is less common. And your average patient with vestibular neuritis has no reason to have any of these central features. So if your patient has any central features, you need to think very carefully about a stroke, no matter what the HINTS exam shows. I can tell you that this patient did not have any central features, so I went ahead and performed the HINTS exam on her. As we saw before, she does have spontaneous nystagmus, and when she looks to the left, the nystagmus increases a bit, and when she looks to the right, it goes away. So it doesn't change direction with gaze. She has no vertical or diagonal skew, and she has an abnormal head impulse test when her head is turned rapidly to the right. The second one was in slow motion. So every part of the HINTS exam gave peripheral results, which means she has right vestibular neuritis. Now what about patient 2? We don't see any spontaneous nystagmus, and as I've said many times before, no nystagmus, no HINTS for you. But does she really have no nystagmus at rest? What many clinicians don't realize is that the nystagmus seen in peripheral causes of vertigo, such as vestibular neuritis, is suppressed by visual fixation. Now what does that mean? Fixation is when you have the patient look at something and keep their gaze on it or stare at it. Visual fixation is a very useful thing for your eyes to be able to do. It stops your eyes from glancing around and allows you to look at what you're fixating on very clearly, and you can observe more visual details of what you're fixating on. The nystagmus of vestibular neuritis can be suppressed by visual fixation. It can either dampen it so that it's not as intense and hard to see, or if the nystagmus isn't very intense to begin with, fixation can make it disappear completely. So if, as a clinician, you're looking for nystagmus, which is an abnormal movement of the eyes, and the first thing you do is ask them to stare at your finger or pen, and in effect tell them to don't move your eyes, then you may be masking some mild nystagmus and miss the opportunity to make the diagnosis of vestibular neuritis. In fact, vertigo-dedicated clinicians who see dizzy patients a lot will remove fixation using Fresnel goggles, which uses strong lenses to blur what the patient sees and remove fixation that way. Fancier Fresnel goggles have cameras to record the eye findings, and some goggles keep the patient in the dark and then use an infrared video camera to record the patient's eyes.
I actually bought a pair of portable M glasses which cost about $130, and they're very flimsy piece of plastic held together by something very loosely, and frankly it only made nystagmus harder to see for me and tended to fall off the patient's face.
So I personally don't recommend that emergency physicians buy or use any of these expensive and somewhat difficult to use methods of removing fixation. But I do think everyone should look carefully for nystagmus in patients with constant dizziness, and that includes removing fixation somehow.
The easiest way to do that is with this piece of equipment. Let's go through how I suggest you use this piece of paper to look carefully for nystagmus, and how I made the diagnosis of vestibular neuritis in patient 2 who had no spontaneous nystagmus.
So this is her looking straight ahead, and again, no spontaneous nystagmus. I didn't have her look at my finger or anything in particular, and I didn't use the piece of paper yet. Then I had her look to the left, and was there a couple of beats of nystagmus? Well, nothing convincing. And when she looks to the right, no nystagmus was seen. So I guess we can't do the hints exam. But what about the magic piece of paper? I'll show you using a styrofoam head how I use it. First, I put it beside the patient's head on one side, have them look through the piece of paper as if it's not there, and look for nystagmus. And then I put it on the other side and look very carefully for nystagmus. So I go to the printer, get a piece of paper, put it beside her head, and ask her to look through the piece of paper as if it's not there, and keep her eyes open wide. And now I'm pretty convinced I'm seeing nystagmus. What happens if I take the piece of paper away? Seems to lessen a little bit. And if I put it back again? Again, the nystagmus is more visible. I can tell you, even with a piece of paper, she didn't have any nystagmus when she looked to the right. So in terms of the hints exam, she had left beating horizontal nystagmus, which didn't change direction. And I can tell you, her test of skew is normal as well. And here is her head impulse test. Normal when her head is turned rapidly to the left and to the right. Ah, there it is right there, a catch-up saccade. And in slow motion, right there. And a slow motion of her left normal head impulse test. So in conclusion, a patient can't be said to not have nystagmus until you remove fixation somehow. And I suggest to you that the best way for the non-vertigo dedicated clinician to do this is to use a simple blank piece of paper and look very carefully for nystagmus to help you make the right diagnosis.
And two last things. I recently retired from clinical practice, and that's freed up more time for me to teach others about vertigo. And the best way to do that is in person. So send me an email, peterjohns84@gmail.com, if you want me to come and teach your residents or attendings about vertigo. And maybe we can work out a time where I can drop by and do some hands-on teaching. And lastly, if you could like this video and subscribe to my YouTube channel, that'll help bring some light to the otherwise sometimes dark world of vertigo education. Thanks for watching.